Good evening and welcome. It's great that there's so many people here reconnecting and visiting, and I think that's what Francis Payne Bolton School of Nursing is all about. So we're very happy about that people are doing that. Anyhow, good evening and welcome. As Dean of the Francis Payne Bolton School of Nursing, I'm pleased that so many of you are gathered here in what is called the Sampson Pavilion, and this is our second DNP Leadership Lecture. Thank you for joining us here, especially those of you who have traveled, and we know that there are many of you who have traveled from out of town and out of state to be here. This is such a beautiful facility, as many of you have commented, and I think you can all really appreciate that Cleveland is one of the top healthcare hubs in the United States, if not the world. At FPB, we're very proud of the role that nurses play to make this university and this city great. You may not realize it, but within a 1-mile radius of where you stand, you'll find 10,000 nurses who work at one of 3 major hospitals, and thousands more work across Northeast Ohio. Our graduates and future graduates, many of whom are here tonight, are among the nation's top nursing leaders, educators, and scientists. And we're continuing that tradition here at the Sampson Pavilion. A key element of continuing that tradition is the Marion K. Shaughnessy Nurse Leadership Academy, established by Marion and her husband, Michael. The Academy was born out of Marion's own experience as a nurse. She saw the challenges that nurses face from the bedside to the boardroom, and the bedroom too, perhaps. She knew that while nurses were in positions to make change, they were not always empowered or prepared to do so. Marion developed the concept for a Nurse Leadership Academy to challenge the status quo when she was working on her DNP under the direction of Dr. Joyce Fitzpatrick. Thank you again, Marion and Michael, for your vision, your support of that vision, and your enduring commitment to the nursing discipline. And thank you, too, to the members of the Marion K. Shaughnessy Nurse Leadership Academy Advisory Board. Would the members of that board please stand? Thank you for lending your expertise. Now let's talk about tonight's lectureship. Tonight is made possible by the generosity and the creativity of the DNP Founders Circle, a group of alumni and friends who support enhancing and expanding FPB's postdoctoral professional development. Thank you for your support and commitment to nurse leaders. Our Founders Circle members here, would you please stand? Thank you. This lecture series, as part of the Marion K. Shaughnessy Nurse Leadership Academy, highlights experts in leadership theory and practice from diverse fields who share their knowledge and understanding with our alumni and students. One of these experts is Dr. Peter Pronovost, whom we are so pleased to have with us tonight. I'd like to ask my distinguished colleague now, Dr. Joyce Fitzpatrick, former Dean of the School of Nursing, who serves as the inaugural director of the Marion K. Shaughnessy Nurse Leadership Academy, to introduce Dr. Pronovost. Dr. Fitzpatrick plays a crucial role in defining the direction of the Academy and in developing innovative and forward-thinking programs like this one this evening. Thank you. Joyce.
Thank you, Dean Musil. I'm very pleased to be here with you tonight and to introduce our speaker and to thank the Shaughnessy's as well as Dean Musil, acknowledge their gift, and thank you, Marion and Mike. So all of you know that nurses deliver 80% of the healthcare globally. And in the US, it's about 30%, and yet we need to empower nurses to take more of a leadership role in that care delivery, and that is what we're doing through the Shaughnessy Leadership Academy. Part of that role, as you well know, is focused on quality and safety. Nurses lead quality and safety. Many of you work in our healthcare institutions where that's particularly important. And so tonight, it's important that we hear from one of our colleagues, Dr. Pronovost, who is an internationally recognized expert in quality and safety for patients. And importantly, you will note that Dr. Pronovost recently joined the adjunct faculty of the Francis Payne Bolton School of Nursing. So welcome. So he, like many of you, is a member of our FPB community. He also recently joined University Hospitals of Cleveland as the Chief Clinical Transformational Officer. So we are going to hear from Dr. Pronovost, but first of all, let me tell you about his role at UH. He leads strategic initiatives to improve value across the health enterprise. He's the clinical lead for population health and high reliability medicine with direct responsibility for the UH employees' accountable care organization. But Dr. Pronovost is not only a physician, but also a PhD, and his scientific work has been focused on leveraging and using data and research to address important issues related to catheter infections that have saved thousands of lives. He's a prolific researcher, an entrepreneur, and a global thought leader with over 800 publications. He's an advisor to the World Health Organization, to the World Health Organization World's Alliance for Patient Safety, and regularly advises the US Congress about health safety issues. Recently, he has been asked by the US Department of Health and Human Services Deputy Secretary with the Deputy Secretary to chair the US HHS Committee on Quality, the Quality Summit. So he has a long investment in helping all of us as healthcare providers address important patient safety issues near and dear to all of our hearts. And we know that his future work with HHS will help us in our future work as nurses. So please join me in welcoming Dr. Peter Pronovost.
Joyce, thank you for that introduction. And Marian and Michael Shaughnessy, thank you for your generous gift, but perhaps more importantly, for your vision to recognize that leadership and nurse leadership are such a key topic to solve this healthcare problem. And no doubt this will be incredibly, and has been, and will continue to be impactful. And thank you for my faculty appointment. I feel like I'm a partner with all of you. I was sharing, I served on, I think, 15 or 16 DMP dissertation theses when I was at Hopkins. So I know the rigors, and I see firsthand the benefits of these types of programs in your thinking and in the benefits of the patients we serve. Now, I'd like you to write down or think about the words, I will. I will. You see, I didn't come here just because I adore Marianne, though I do when she asked me. I came here so you'll do something. Because your patients and the country need you. Though our healthcare system in Cleveland and in New York and around the globe perform miracles every day. The sad reality is today in medicine, preventable harm is at least the third leading cause of death. Sadly, we don't really know how many people are harmed, but it's at least that. And if you add not controlling people's blood pressure or not controlling diabetes or misdiagnosis, it is by far the leading cause of death. Think about that. The leading cause of death that we don't need to wait for some biomedical discovery. You are the cure. You just don't know it yet. Medicine today leaves somewhere between 2 in 10 and 4 in 10 patients leaving their interaction with healthcare saying, I wasn't respected, I wasn't listened to, and I'm scared because I don't know what to do when I get home. And medicine today squanders a third of every dollar we spend, $1 trillion or $1.2 trillion now, on therapies that we might as well just burn. It's a mind-boggling number, but to put that more in perspective, it's about $10,000 per household. That's more than the median net worth of the people who live around us here. And if you look at every payer in healthcare, the federal government, state government, municipalities, employers, and us as individuals, many of us with high deductible plans, our healthcare costs are going up more than our revenue. And Michael, as a businessman, those economics don't work for too long, right there, and it's not a sustainable model. Now, our policy approach as the federal government is taking this mindset to say, doctors and nurses, the solution is you just don't care, and so I'm going to take a nickel out of your pay or give you a nickel if you don't hit these now 2,300 measures, like just playing whack-a-mole on all of them, and that's somehow going to solve this problem. And no doubt we need to align the economic incentives. They're not aligned, and they are. But that alone isn't going to solve the problem. I mentioned you are going to solve the problem, but something deeper, something within all of you that you'll have to wrestle with. And that is the stories that you tell yourself. You see, stories are the most potent force for change in the world, by far, because they define how we act. The story of capitalism or liberal democracy or Martin Luther King, nonviolent protest, or JFK, I want a man on the moon. You change the story and you change everything. And healthcare now is guided by this really dysfunctional narrative that success is having people heal in hospital rather than healthy at home. Right? And we all go through this. I've done many, many board presentations where I share a patient who I know, and her name is Helen. Helen's employed by an employer in the community. And Helen has had 35 heart failure readmissions in the last year. And every time Helen showed up, the part worked brilliantly. She showed up at the ED, they did what they were supposed to. She showed up, got admitted, they diuresed and afterload reduction. She went to her cardiologist afterwards, she filled her prescription. But the system failed her because we didn't connect those parts. And from most hospitals or a board perspective, every one of those 35 admissions is a win. You're filling my beds, that's success, right? But from the person who's paying that, and most importantly from Helen, it's a disaster. Every one of those is a defect. They're failures, they're preventable. And how do we begin to change that? Well, I want to explore 3 sub-narratives that are driving that. Narratives that we need to change. And I'll share with you my own journey of how I've come to understand and reframe these new narratives. First narrative, stop believing that harm is inevitable. Start believing harm is preventable. You see, I learned this in 2001 on a snowy night when this little girl in a dark corner of the pediatric ICU at Hopkins was taken off of life support and died in her mother's arms. She had been burned, but was healing, was actually supposed to go home that day. But a catheter infection sacrificed her. At the time, the prevailing wisdom was that these catheter infections happen when you care for sick or old people. They were just the cost of caring for sick people. We all were trained that sometimes little girls like Josie are going to die. And she did. And she was in a lot of company. At the time, these type of catheter infections, one small part of the safety problem, killed more people than breast or prostate cancer. Think about that. A public health problem the size of breast or prostate cancer that we just accepted as the cost of doing business. I accepted as an intensive care physician as the cost of doing business. Until her mother started working with us, and she spoke with me and she said, "Peter, could you tell me that this won't happen to my other two daughters?" She was worried. And I wanted to give her the spiel like any executive does, where you tell her all the great stuff we're doing about quality or safety. And I had this moral moment because I started to speak and I paused and I said, "I can't tell you that. Our rates are sky high. We don't have a great program. There's no science base to it, but I will. We'll put a program together." But then she said something that changed my life. She said, "Peter, what are you going to do about it?" And in that moment, I knew we could no longer accept these as inevitable. So we did something that my colleagues thought we were crazy. We declared a goal of 0 infections. And everyone said, "But we're at the CDC average." And I said, "Yeah, the CDC average is 70% of people not doing what they're supposed to. It's stalling progress. Don't get anchored to a crappy benchmark." We created a checklist of best practices and made it easy to use that. We got doctors and nurses to work together and empowered nurses to say, if the doctor isn't using this checklist, you could stop, take off, and you will be supported. And my friends, that is a whole nother lecture, or maybe it's a whole nother leadership stories. It highlighted to me the great importance of leadership and culture, because nobody debated whether the checklist was the right thing to do. What we debated was power and politics, where the doctor said, "You can't have someone question me in public. It hurts my credibility." And nurses saying, "If I speak up, Peter, I will have my head bit off." And that's the culture that leaders tolerated, and it was unacceptable. Third thing we did is we fed data back into the system. And fourth, we created accountability where leaders had to review these infection rates and make sure that there were active plans working on it. Not rocket science, good leadership that was absent. Well, these infections rate, if to bore you, went from around 14 per 1,000 catheter days to 0. A program was spread state by state across the country. And now these infections that used to kill more people than breast or prostate cancer are down 90%. Here in like 15 other countries now, 90%. So we got curious to say, oh, thank you. What changed with this program? Because something clearly was unique about it. And the media wrote that it was all the checklist, and I said, I wish a checklist was Harry Potter's wand. They're good, but they're not that potent. There's something deeper going on. So we partnered with some nurse researchers, some anthropologists, some medical sociologists, and interviewed clinicians to say what helps change what happened. Well, how do we explain these results? And what we found was immediately eminent. When you started speaking with clinicians, you immediately could see in their eyes what they believed in their hearts. What they shared was the secret sauce, was they started telling a new story. Routinely, nurses and doctors would say, when we started this, we used to say these infections are inevitable, and I'm just and fill in the blank. I'm just a charge nurse, I'm just a staff nurse, I'm just an attending, I'm just a resident, uniformly. That I'm just is probably the most destructive phrase in the human language. And they got to 0 when the staff said, no, these could be 0, and I am powerful to do something about it. Once they told that new narrative, they didn't need a checklist. The rest of it, they figured it out because they changed the story. So we got curious to say what leads to new narratives, because if you could tap that, you have a really potent force for change. Turns out there's a robust literature, we had to unfortunately reinvent it, that says what leads us to tell new narratives. And it's 2 things, believing and belonging. We tell new narratives when usually leaders message that we could get to some goal so that we internalize it and we believe it ourselves. Right? And we are horrible at this in healthcare. Right? To give you an example with patient experience, I have so many executives say, our scores are low because we have double rooms, or because we treat really rich people or very poor people. Right? And what I routinely say is, what your staff are hearing you say is you don't believe in them. right? Believe in them. They're really good. They could hit this out of their mark. Example of believing I'll share with you comes from the story of Mary Poppins. And how many of you have seen that play or movie? So you probably are familiar with a very prominent feature of the play is birds chirping in the background when she's caring for the kids, when she's skipping, when she's flying down. And that's because in the late 40s, London was full of two types of melodious songbirds, the red robins and the blue tits. And they used to thrive in downtown London because they pecked through the tops of the milk containers that were left at people's stoops. They sucked the fat out, and they were really chubby, really plump, happy birds, and they sang a lot. But then the milk companies changed the containers from cardboard and steepled to aluminum and flat. And a few of both birds learned the new way to peck. They're both equally smart. But the red robins went extinct, and the blue tits thrive today. And the only difference is the red robins are solitary birds. They have their stoop or their corner. We call it our department, our hospital, our school, our discipline, and that wisdom never disseminated. The blue tits are flocking birds. They fly strong and proud together. They have a structure for knowledge dissemination, so that wisdom quickly disseminated. And my friends, when I think of almost any problem we're facing in healthcare, just even in Cleveland, let alone the people in this audience, there is a solution to them in your organizations. The question is, we're too much like the red robins and we don't cull that out. We don't have the structures and cultures to cull that out. The second part of creating a new narrative is believing. Believing is probably best exemplified in the story of Roger Bannister breaking the 4-minute mile. Now, I'm a runner, so pardon the sports metaphor. But prior to Bannister breaking the 4-minute mile, leading scientists at the time, actually I believe some leading case scientists, said it is physiologically impossible to break the 4-minute mile. You will die trying. That message stood since the first Olympiad for 2,000 years, until Bannister in 1954 broke it. And he didn't die, and you may know that story. But what's often not known is the next year, this impossible record, 12 people broke it. The year after that, 156 people broke it. And now high school kids are breaking the 4-minute mile. And the last New York Marathon runner ran a 4-minute mile pace for the whole 26 miles. So what changed in 1954? Wasn't doping or steroids or new sneakers or evolution. It was their belief. Bannister freed up all to break that 4-minute impossibility. And folks, that's what we need you to do in healthcare. Second narrative that we have to break is stop believing that value's not my responsibility and start believing that it is all of our responsibility. You see, value, we'll define it, or I'll define it, you may use your own definition, is the quality of care we give plus the experience of that care over a person's annual total cost of care. Because that's what every payer looks at, including us as individuals. And when we start thinking about our responsibility for annual total cost of care, we look at Helen as a failure, right? Because she genned up $1.3 million in charges that she paid for some now declared bankruptcy, because even with insurance, we all have co-pays. Co-pays on that degree of bill adds up to a ridiculous amount of money. Her employer paid for it, or taxpayers paid for it, and it forces us to think differently. We need to start to think as a system, meaning a set of parts interacting to achieve a goal. I'll share with you some of the new thinking we're doing on this, and nursing plays an enormous role in this. When we look at what keeps people healthy at home, there's 4 key interventions that seem to do and have an impact, but nobody's put them together yet in a systematic way or as a system. The first part is ensuring people are competent in self-management. Right? And I know you have the Center of Excellence in that, but when you go into any health system and say, who owns ensuring people are competent in self-management, you get like a whole lot of this. Some of the hospitals, they have this older view of it's educating patients about their disease, which is very different than I know how to live well with my disease, and they're never home. UH now, our home healthcare team owns it. They produce content once, and we disseminate it to the hospital, to a home healthcare, to our ACO, to our primary care, to our urgent care centers, because we were confusing the heck out of people, giving them different information, supposedly on the same topic, but it was all disjointed. Second part of what we call this web of well-being is the dose of social support systems. We know social determinants are enormous, but we haven't had a systematic way to make needs visible and to close those needs at various touch points. And again, our social work is taking the lead on that, of standardizing when people show up in the ED, in ambulatory, when they're leaving the hospital. How are we identifying and closing those gaps? Third part of the ring, really, really innovative, is the dose of ambulatory care. The dose of ambulatory care. We, as clinicians, titrate any drug to a physiologic endpoint, a heart rate, a blood pressure, a glucose level. We asked our primary care docs, how do you titrate your dose of ambulatory care? Think of it as a drug, or a dose or dose frequency in people with chronic disease. Because we have 40% 90-day readmission rates, seems like your dose is pretty too low. So how do you decide that? And it was like a light bulb went off. They said, I just wasn't mindful of. I really never was intentional. I didn't think about it. Most of it's around my schedule. I guess I see them kind of whenever I was free. I said, okay, wrong answer. I don't know what the right dose is. We know your dose is too low, so we're going to titrate it up. And by dose, I don't mean just primary care. By dose, we mean all of that ambulatory space. So chatbot to communicate with people, home health call or visit, televisit, our ACO navigators outreaching, our PCP visits, behavioral health specialists, because we know if you take someone with heart failure, they spend in our system $41,000 a year. You add depression to that, they spend $100,000 a year. And that gap exists for almost every disease, at least doubles it. But behavioral health was never part of this web. They were always separate in their own thing, as was palliative care. So it's all part of this web. And the outer ring is the acute care system. Obviously, it has to work when people need it and not harm them and deliver it well. But we also need to realize 40% of people in acute care system could be cared for better at home or someplace else. That success isn't filling your hospital. Success is driving value. And how do we navigate that? I won't bore you with the details, but we just launched this Web of Wellbeing pilot at Geauga, one of our hospitals. Readmission rates went from, our 30-day readmissions for heart failure went from around 16 or 17% to 0.5, 1, and next month 1.5%. Like unheard of reductions. And not because that this is some magical model, but we evolved from thinking of my job as the part to my job is a system. And the leadership required to make that work was the biggest challenge, because as you heard me just say, it involved primary care, it involved home health, it involved the hospital, it involves behavioral health colleagues, it involves the ACO. These people were all in silos, right? They were classic Red Robins. They literally never talked to each other, understood what they do, but now they're all working together on weekly calls. They're on the same platform for scheduling people. We're using the same care management tools. And it's just, the possibilities for this are enormous, but it requires us to work as a system. But it also requires us to engage every employee in this journey to value. You see, too often we thought this value journey is doctors and nurses, maybe pharmacists. We haven't thought of it as EVS workers. We haven't thought of it as dialysis techs. I learned the power of this deeper type of thinking of engaging everybody when I visited an aircraft carrier. And as you may know, aircraft carriers are the prototype for high reliability. High reliability meaning industries or organizations that work in really hazardous and dynamic conditions and yet seem to perform flawlessly. They works with really, really few errors. So they've been a study of many people, including myself. And they do three simple things. They aggressively reduce mindless variation, but they augment mindful variation. right? In healthcare, we have a ton of mindless variation and not enough mindful variation. Mindful variation where I have a hunch this patient's different based on my clinical experience and I need to deviate from a protocol, but most of the time we don't have protocols. Secondly, what they do is they have a personal commitment, their I will statements, to own safety and value and to continually improve. And third, they have profound cultures of respect and trust, where every member of the organization, they're building trust upstream and downstream, so that systemness that I said in the web of well-being is natural, because they always try to say, who am I handing off to? Not like our Red Robins. I saw that in action as I was speaking to the admiral on the aircraft carrier. There was a gentleman sweeping the deck next to him. Now, on the power hierarchy and the pay hierarchy, that gentleman is way below the admiral, right? He maybe has a high school degree. On the safety hierarchy, they're exactly equal. Because if there's a hammer or debris on that deck and a plane comes down and hits it, they all blow up. Just like the dynamics between an EVS worker who's cleaning a room for MRSA or C. diff. If they don't know that protocol, how to clean, patients get infected and die. But power hierarchy is different. Safety is exactly the same. Well, I asked him, what job do you do? And I was blown away. He stopped what he was doing, put the broom down, stood up tall and proud, looked me in the eye and said, sir, I help planes take off and land safely to serve the mission of the United States. I said, wow, that is a worker who's connected to their purpose, right? That's leadership. I walked into now hundreds of hospitals and asked an EVS worker, what job do you do? And what do you think they say? Yeah, even, I think perhaps more painful, is they looked away shameful, truly shameful. There was no connection to purpose, and say, I clean the rooms. And I said, no, you don't. You prevent infections, right? You are an infection prevention specialist. Or ask the transporter who have enormous opportunity to create healing moments and say, what job do you do? And they say, I just transport people. And say, no, like you have this connection when you're with them. They're often the most consoling moments. Or a radiology tech when someone's waiting for a film. Or you answer the phone call system. Same thing. What job do you do? I answer the phone. I say, no, where do we go wrong? You are a healer. Someone is calling. They're anxious. They're frightened. And you have that ability to connect with them for a moment and to relieve their suffering. That is a gift that you have to leverage, but we haven't created that kind of leadership culture. We are now with your academy, so thank you. But that's what we need all of us to do as leaders if we're going to create this kind of culture. And we got to be much more like the blue tits and go out and connect, break these silos of saying, I can care less where your P&L reports, because leadership and population health is all about horizontal and indirect influence without formal authority. Let's get together and solve this problem. The third narrative that we need to frame is stop believing that economic incentives alone are going to solve this problem, or you crank up your RVUs enough and you're going to cut your budget enough to solve this problem. Not happening. Start believing that the secret of high quality care is love. Love. And by love, I don't mean a 50-year marriage, though there's certainly love, hopefully, in a 50-year marriage. By love, I mean what the psychologist Barbara Friedrichsen describes in her brilliant book, Love 2.0, where she studies the biology of love. She literally looks what makes oxytocin spike. As you know, oxytocin is the cuddle or the nursing hormone or the orgasm hormone. It's what spikes. And what she found is that oxytocin spikes, love increases in micro moments of connection between people. Micro moments. The idea is I feel warm towards you, you feel warm towards me, and we create energy. Love is a hand on a colleague who just made a mistake. Love is listening patiently to a scared person. Love is seeing that patient who's walking around our hospitals, who they do every day, who's lost and worried, and taking the time to walk them to where they go. You see, because as clinicians, think about your most memorable moments in healthcare. Those things that you draw power from and strength from. I guarantee you they're not some brilliant diagnostic that, made some great therapy or some great surgery. They're micromoments, right? There's something small, intimate connection. Because this big change that we're embarking on to drive value, and it's scary because there's no real roadmap, is made up of hundreds of smaller changes, and every one of those is facilitated and starts with a micromoment. Change progresses at the speed of trust, and trust grows when we do things with rather than to others, and that with is all about micromoments. Share with you this micromoment of applying some of these principles. We were sharing with some of our dialysis techs about how we had we could be higher referral to transplants for people on dialysis. As you know, it's life-saving. The mortality of dialysis is worse than cancer, but we weren't referring them to enough. We met with our nephrologists and our dialysis techs and said, these people trust you. They're with you 3 times a week for 2 hours. What if we gave you some talking points about encouraging them about the benefits of transplant? They trust you. Would you be engaged in using your skills to build a micromoment, but to see every member of the care team as important? To date, as you may know, they weren't really viewed as part of the care team. They were a tech, but they had a very limited role. So lo and behold, put a training program in, referrals are up 45% to transplant, but no cost. Simply, they had a trusting relationship with these people, and we scripted or navigated this conversation about how the benefits with our transplant, and they might receive it. The beauty, the gift of these micro moments is that they're infectious. I don't know how much you're familiar with the sociology literature of this brilliant, he's also a physician, Nick Christakis. He wrote a book called Connected. He published it in the New England Journal, showed some great studies where if you put a fit person on a team, not only is that team and their friends more likely to be fit, but 3 networks deep, their friends' friends and their friends' who don't even know each other are more likely to be fit. The dose effect goes down, but it's still there. Likewise, you put a jerk on a team, and as you all know, it poisons. It poisons 3 rings deep. But you put somebody who creates micromoments, and it's infectious. They spread. I learned about this power of infecting love in a really unlikely place at a Dunkin' Donuts in Baltimore. You see, like Michael, I'm an intensive care physician, and as routine Sunday morning, the attending would buy bagels or donuts for staff, for people who are working there. And the Dunkin' Donuts I stayed at was around the corner from a homeless shelter and under a highway that was protected and around the corner from a bail bond. So Dunkin' Donuts was half full of homeless people on Sunday morning because it's warm and dry, and half people going about their work. Nurses, firefighters, policemen, Sunday school teachers. And I'm in line in Dunkin' Donuts, and it's the Sunday before Valentine's Day, a cold, chilly morning, and there was a homeless couple in front of me. And I can't say I've seen many homeless couples, and they were dirty, yet you can tell deeply in love. And they were seeing if they had enough change in their pocket to buy the heart-shaped donut with pink frosting and little pink sprinkles that they release at Valentine's Day. Some of you may have had this. And they were a nickel short. And so the woman turns around and says, "Hey, could you give us a nickel?" And I was feeling quite guilty that I was buying bagels and donuts for most of the people who didn't need them. And this was probably going to be this couple's only meal for the day. And I said, I'm getting an order. Why don't you just go order breakfast? I'll treat you to what you want. So they go up to order breakfast, and the cashier must have had implicit bias because the cashier said, "You can't order all that food. You don't have any money." And the guy made a scene and said, no, the guy behind me said he'll buy me breakfast. And I said, "Yes, I'll buy him breakfast. They can get whatever they want." Well, the nurse standing next to me said, "Well, that's a cool idea," and turned to the homeless person next to her and said, "Can I buy you breakfast?" There was a cop on the other side of me who said, "Can I buy you breakfast?" There was a Sunday school teacher behind me, and this love cascade literally went 7 people deep in 30 seconds. I was the most moving experience I've ever had in my life. And I was walking out, and the couple said, "Could we speak with you for a minute?" And I said, "Oh, of course." And they said, "We're not nobodies. We just made some bad decisions in our life." And I said, "Yeah, you and all of us together." And he said, "Well, we're going to get our act together." And I said, "I believe so much you will, do me a favor. I believe in you. When you do buy somebody breakfast, so fast forward to June, I'm schlepping in on a Sunday morning, tired, going to order my bagels for the staff, and the cashier says, "Hey, Doc, some guy left this note for you," and written in a little crinkled piece of paper in pencil was, "I bought somebody breakfast." And my friends, that's what your leadership challenge is all about. Because healthcare needs you. Your patients need you. And it's not going to come from alone from public policy. We need you to infect a belief system where we stop believing that harm is inevitable and start believing it's preventable. Where we stop believing that value is not my job and believing it is deeply my job. And we stop believing that economic incentives alone are going to solve this problem. And we start believing that it's all about love. So I'd like you to either reflect on, or we could have conversations about, what's your I will statement to go drive this value so that we provide the kind of care that our patients deserve, that all of us as providers desire, and the public and the payers demand. So thank you, and thank you for inviting me and for your generous gifts.
So glad to have you as part of the FPB family.
It's my honor.
And do you have any? Yes.
Important working as a team is. And one of the things that I, as a physician, am really concerned about is the percentage of our colleagues, physicians, nurses, pharmacists, that say they're burned out, that we are demanding, I think, so much of them, and yet I'm not sure we've paid really great attention to taking care of them, or as a system taking care of them. So do you have any ideas around, because in my experience as an intensive care doc, more burned out people are not as compassionate, don't pay as close attention to safety. Do you have any ties between the burnout scourge and this particular topic?
Yeah, so Michael, great question, and as always, really insightful and keen. There's no doubt burnout amongst healthcare professionals is an enormous epidemic, and that it has negative consequences on many things. I mean, suicide rates, economic productivity, the well-being of the clinicians, quality and safety. I mean, you will never get a high-value health system if you don't have your employees without burnout. And there's some really compelling data that their ability to ingest any kind of change is virtually non-existent, right? And if I were to say, what's the one leadership skill that we all need is how to lead change, because that is, the change we're facing is so enormous. People who are burnt out, psychologically, they can't even react to it. There's been a lot of work important, but I think we failed as leaders to put the responsibility on self-care and wellness to solve this problem. You know, if you just go meditate, or you go for a hike, right? Exactly right. And I don't mean that those things work and they're important, but as leaders, there's structural things that we can do to address this. And most importantly, we have to honor our clinicians and trust their burnouts. Too often what I hear is that they just don't like the EMR, they're dissatisfied. Well, no, the EMR, in fact, it's probably the main thing we bought from EMR is burnout. Right? That's what we paid an awful lot of money for. And we have to have it be very intentional about addressing clinicians' dissatisfiers and reducing them. I'm going to give you an example of something I'd love some partners we're working on now is, we have reducing margins. I get it. We all live we have to balance productivity and safety. But our view of growing productivity is having staff run faster. I mean, literally, it's naive. We don't give you any better tools, and we wonder why burnout. I had a piece in Health Affairs a few months ago where there were 5 simple things that each hurt nursing productivity by 22%, that are solvable with existing technology that we just haven't solved, but that's real productivity gains, right? Where I don't just say run faster. Examples are nurses spend, or you know all better than I do, 22% of their time hunting for supplies because nobody managed the last 10 feet of supply chain, right? We all care about our contracts and upstream, but then you literally hunt for meds, for commodes, for tube feeds, truly like ridiculous, right? That's a solvable problem. Nurses answer a false alarm every 94 seconds, right? Solvable problem with technology. And yet we haven't really invested in the solution. So I think what we need, and hopefully this group could help focus on, is some real productivity gains that reduces that burden. So we don't just say work harder because my budgets are, but we truly get gains in that the productivity that are so desperately needed.
Enjoyed your presentation so much, and University Hospital and Case are really lucky to have you.
Thank you.
You mentioned that what we really need is to have all leaders understand how to move change forward, and I think the first step in that really has to do with culture and the politics piece. So you can could you talk a little bit about how to really change a culture that's a culture, the one that you've talked about, we need to have, where people tell the truth, where people work with each other, and how long of a duration do you think this really takes in a place like a university hospital? I mean, you've given examples in particular places, but for a whole institution.
Yeah, great question. And I'm going to take that two parts, because I think one is how do you change culture, and then maybe if I could, a few minutes on how to lead change, or what do we do about that, because there's great data that we do it really poorly in healthcare. Culture. When we talk about culture, let's just level set that we often are using different things. When we think about culture, or this is a model of Edgar Schein, is we think of culture at three levels, like a water lily. The first is what you see when you walk into a place. Are people working together? And that's often the superficial value. The second level, the stem of the water lily, is what the espoused values, right? What I read on my mission statement. We are for teamwork, or when the Joint Commission comes, what you tell them. The deepest level, and where the power is those unstated assumptions, where you say, where people don't speak up, where I'm never going to administration about this, they'll bite my head off, right? Or a nurse, I'm not speaking up to that doctor because they got really aggressive the last time, and that's the richness. When I think about culture, it seems so daunting. The reality is we all make or break culture every day. And we are the culture. Culture isn't something external, and there's microcultures. Your unit, your area has a culture, and it has a half-life of epinephrine. I mean, if you have to begin to take actions, and it's scary to shape culture. C.S. Lewis has this beautiful quote, when I think about culture, it says, "Courage isn't one virtue, it's the form of all virtues at the testing point." Right? And shaping culture in a place that is not there yet is really courageous. It's scary as heck. As leaders, there's, at least in my simple world, you don't have to buy this, I seek to intentionally shape culture through four levers: my rhetoric, my rituals, the recognitions, and the rewards. Right? And rituals, rhetoric, recognition, and rewards. And if you want to drive culture, every one of those things need to be intentionally and mindfully scripted and designed every step of the way. I mean, think about the words you use. If you're a CEO and all you talk about is bond ratings and my margins, and you don't talk about Helen, but then you say, we really care about people, like, culture's not going to change, right? The rituals that you do, what do you do for rounding? The ceremonies, the lectureships like this need to be really, really thoughtfully and intentionally planned out. What you recognize either in celebration and what you reward in incentives, right? I mean, and believe me, we're struggling with this. If you look at on the physician side or the APP side, many incentive systems only reward RVUs. That's it. You churn RVUs, that's good. No value, no experience, no quality. So what signal are we sending? And then we message that we want to be value. So my plea would be, this is something that's in our power to shape, whether it's in your micro system or the bigger system, and be very intentional about those 4 R's, as I call them, and how you are very intentional about the words and the rituals and the recognitions and the rewards. Let me share with you a concrete example. I'm sure they'll be happy to share it. One of the hospitals in our system was struggling with quality and its patient experience, virtually every one of our quality measures. And some of it was for budget pressures. You could say it was complex, but at least in my view, the fundamental driver was their nurse to patient ratios were way too low, right? I don't have to tell of you get above 1 to 7 or whatever you want to say, and you don't have a prayer of changing culture. And so we worked to shape that and to try to do it, but their turnover was really high. And the CEO and the CNO were together, and we said, okay, we're first going to stabilize the base with this new culture, and we want to evolve to a better culture. And he said, you have to apologize. And it was like, what do you mean apologize? Like, I wasn't in my control. I was forced to do this budget. I said, I get it. But as a leader, no one's going to be receptive to this new cultural way unless you build trust and heal the past. They're going to be viewed as empty words. So you could not apologize, but then you're wasting your time trying to do these things because you'll always be viewed as, I'm still wounded. I'm still hurt. I think the same approach is for a lot of the racial issues that we have. We have to acknowledge them. And so we did this, and I said, we need some ritual that is a healing ceremony, but is also a rebirth. And so we invited all the staff in. We had a tree in the lobby, a new tree that was a symbol of rebirth. The CEO and leadership apologized and then had all the staff write their name and pin it on the tree as a symbol of we're joining this new journey. And I won't bore you, but their turnover rate went from like 25% to 2%. Their patient experience flipped, their infections flipped, but it was very intentionally shaping culture. And sadly, we told that story. I think I have 10 hospitals around the country who literally have the same outreach. Hey, what do we do for this? My nurse to patient ratio. They're suffering on measures, but when you peel the onion, their staffing's too thin. They see staffing as a cost rather than as a value driver, and they need to go through a process. So great question. The piece about leading change is absolutely key. There's great data that good change management matters, but 85% of change projects fail, and almost none of them have a framework. You don't necessarily need a framework, but they just shoot from the hip, and they wonder why change fails. We use in all of our change efforts this model or modified model from this guy, Ron Heifetz, that separates change into a technical component and adaptive component. Technical component is lean, the measurement, evidence-based project management. Adaptive is getting the buy-in of your staff, right? And if I were to ask you, why do you think most change projects fail? Do they fail more for the technical side or the adaptive side? Adaptive side. And if you look, where do we spend 95% of our time? On the technical, right? Why? Because none of you got where you are without being really good at the technical side. But it's not enough. Change doesn't fail for that. The technical needs to be right, but you get your DMP programs, you darn well better be good at that. The problem is nobody's trained you on the adaptive side. And so a lot of the leadership training that I do is building clinicians with skills to say, how do you lead the adaptive piece of it? Things like change progresses at the speed of trust. So never do things to people, always do them with them. Your job as a leader is to say why we're doing things and what the goal is, but keep your paws off of how. How is your staff, right? But so even in my own work, so many times I'd have a nurse leader who say, Peter, I read your work, I love it. I told my staff they will use this checklist. And I'd say, boy, bet that didn't go over too well. No, it won't, but I'm going to force them to do that. I said, okay, do not use the Johns Hopkins checklist at the time. It's not going to work. How about if you show Josie's picture and say, we kill 100,000 people from infections, and in our hospital, it was whatever it was, 30 people last year. And I think we can do better. I want a goal of 0 infections. Could you help me figure out how to do that. Here's this hospital checklist. You don't have to start from zero, but don't use it, make it better. And that was the script. I'll give you an example. When we look at hospitals who got to zero, they all had a checklist. And they were 95% the same, but that 5% difference made it work. And they all had it the same way. Nobody called it the Peter checklist because we told them not to, or the Hopkins checklist, right? It was the St. John's or the whatever it was, NYP checklist, intentionally, because if you don't have ownership, it doesn't work. I'll give you one of the other metaphors that we use, a couple metaphors for leading change. One of the papers I wrote is navigating adaptive change, if you're interested in it. But how many of you think your staff resist change? Right? Everybody says that. Let's think a little deeper like an anthropologist and say, if I were to give your staff for the Ohio State Lottery or the New York State Lottery that pays $500 or $600 million, would that change your staff's life, right? Unless they're independently wealthy, enormously. And how many of them would say, no, Peter, you keep that lottery ticket. I hate change. I don't want your $600 million, right? It wouldn't happen because people don't fear change. They fear loss. And loss has an often small real component. I want you to work a little bit differently, but a much larger perceived component that grows like a cancer if you don't manage it. And it's often perceived loss of control, my stature, because you're embarrassing me, my budget. And there's tools to help navigate that, but we often aren't mindful for it. And so one of the metaphors that we use, it's a cute story I call is avoiding monsters in the bathroom. So my son actually just graduated from college last year, but when he was in third grade, he came home from school and said, Daddy, I'm afraid to go into the bathroom. There's monsters in there. And I'd say, yeah, Ethan, okay, whatever. Next day, he comes home again, really scared. Daddy, I'm afraid to go in the bathroom. There's monsters in there. So I called the teacher and said, hey, what's going on? And she chuckled and said, oh, we just installed automatic flush toilets and nobody told the kids, right? Now, we think about that, but think about how you roll out a protocol or an EMR and you're a night shift nurse or you're a private practice doc and they're not at the management meetings hearing all this and it's just stuff thrown at me and you wonder why you get rebellion, right? Because it's monsters in the bathroom and they weren't intentional enough to say, I got to manage this change. I need a containing vessel to make sure they know that. The tool we use to do this is this concept from nature called a fractal. So think of it as a fern or broccoli or alveoli. It's identical shape but varying size structures. And that is we intentionally say from board to bedside, every higher level in the organization needs to have a table where every lower level has a voice to co-create, to understand why, and for peer learning so they can be like a blue tit. And it may sound laborious, but it literally is at a health system level, at all the different components within a hospital departments, within departments units, so that we manage this structure. Probably the most important piece of adaptive change, and it goes back to my love, is value the dissenter or seek first to understand. You see, one of the problems we have, perhaps in politics, but certainly in quality, is when we believe in something, we don't just think we're right, we often get righteous. That is, those docs don't want to use my tool, I'll force them to use it, right? Because we believe so much in this quality, and we get into this us versus them, or I'm right and you're wrong mentality, and we don't approach this from positive intent. And I believe this is key, saying people are in healthcare, for the most part, the vast majority, because they want to do good. They want to give high quality care. So if that clinician or administrator is resisting, there must be something that I'm not seeing. So your job as a change leader is to understand what that resistance is. And so my script when I'm working with someone, I would say, Bonnie, I know you're really committed to quality, as am I want the best. So could you help me understand why you seem not to support this effort or whatever it is, why you don't want to use this protocol? Because from the way I'm seeing it, it's going to help your patients do good. So there must be something that I'm not seeing. And I'll share with you, after doing this thousands of times, 99% it's miscommunication. I didn't know you wanted me to do that. because we hid monsters in the bathroom. Now that you explained it, I'm happy to. Or the other percent is very real. Well, do you know if I do this, there's this unintended consequence over here? I'd say, thanks for making me aware of it. I didn't know that, but I think we can solve for both of those things and make progress. So programs like you've put forth are so key because we need to equip leaders with tools to how to lead adaptive change so that you're as comfortable with those as you are on the technical side of running an Excel spreadsheet or doing a lean project. I think I've blabbered on for you long enough, and I don't want to stand between your wine. So thank you again for having me. And